Today, the topic of our discussion is hepatobiliary trauma. We will discuss our this slide under etiology, pathophysiology, clinical features, workup investigation, differential diagnosis, injury grading by CCT abdomen, treatment and complications, and treatment algorithm. At first, I want to discuss about the spleen trauma. For discuss about that, the etiology or history of blunt abdominal trauma or lower thoracic trauma, penetrating trauma at the left hypochondrium. Usually, the mechanism of the injury is crushing, deceleration, sudden increase in the intra-abdominal pressure. Injury, if we consider the injury type, these are the laceration, subcapsular hematoma, injury associated with other organ injuries, and hilar injuries. Pathophysiology classically associated with the left lower rib fracture. So if we consider there is rib, here it is a rib and this is in the left side. If there is fracture in the left lower rib, then it could be happen. A delayed rupture of the characteristic features in the subcapsular hematoma. A ruptured spleen can cause life-threatening bleeding into abdominal cavity. So, initially at the time of injury, we could see there is no injury, but later on when we observe there may be rupture of the spleen. If we consider this is there is a spleen, initially there may be no injury, but later on there is injury and subcapsular hematoma. Ruptured spleen can cause life-threatening bleeding into the abdominal cavity. Now, if we consider the clinical feature, the history of trauma, pain abdomen, occasional distension and vomiting, in severe bleeding associated with shock. In severe bleeding associated with shock, syncope or dizziness, pain over left shoulder and Kehr sign. This is a very atypical sign which is known as Kehr sign. Fixed dullness to the percussion on the left and shifting dullness on the right. This is the balance sign. The balance sign is when there we percuss on the left and a shifting dullness on the right. If we start the percussion here, if we percuss, there is what? Dullness. Then there is shifting dullness on the right. Then there will be tenderness all over the abdomen with or without guarding and rigidity. There is all over the abdomen there is tenderness. This is very important feature. With or without guarding, there may be and rigidity. There may be guarding, there might be no guarding, but there may be rigidity. And very important feature, bowel sound is absent. Differential diagnosis, other cause of hematuria. There may be also liver injury, very important organ, liver. There may be associated liver injury. Ruptured ectopic pregnancy, there may be also ruptured ectopic pregnancy. So we should also keep this in our mind that this could be ruptured ectopic pregnancy. Ruptured abdominal aortic aneurysm. There may be abdominal aorta and there may be aortic aneurysm, and this aortic aneurysm may be ruptured and acute hemorrhagic pancreatitis. So the pancreas is here and it could be acute hemorrhagic. There may be bleeding, hemorrhagic pancreatitis. So it could be also another one. Now if we consider the investigation, there are various investigation. One is ultrasound. There is ultrasound. Another is CCT abdomen. There is CT scan of the abdomen. So we also have to consider this. There may be CT scan of the abdomen and selective celiac arteriography. This is also some kind of CT scan, but here we can see the celiac trunk. Observe the celiac trunk and celiac trunk arteriography. By doing this, we can see the normal anatomy. Then we can also diagnostic peritoneal lavage, TPA. Actually, don't know. Later on, when I will know, I will let you know. The ASST grading. So we have to know about the AAST. So what does the meaning of AAST? It is very important that we have to know the meaning of AAST. The A is for American Association for Surgery and Trauma. So there is two things here. One is hematoma, one is laceration. One is hematoma, one is laceration. So here, if we consider it, first is hematoma, subcapsular hematoma. Here we can see here that the hematoma is subcapsular less than 10% and capsular tear less than 1%. If we observe here, here is hematoma, here is hematoma 1, here is the hematoma less than 10% and tear less than 1 centimeter. Now again we observe the two again, the subcapsular hematoma 10 to 50% of the surface area intraparenchymal and less than 5 centimeter diameter. Laceration 1 to 3 centimeter and 10 to 50% of the diameter. 3 hematoma subcapsular less than 50%. Then hematoma subcapsular, again if we observe, it is a hematoma 50% and there may be rupture. So more than 50% area and there may be rupture subcapsular or parenchymal hematoma. So here there is subcapsular hematoma, it is more than 50% and laceration more than 3%. Here there may be associated rupture. We have to consider this is rupture. Okay, maybe rupture. It is grade 3 and this is also same in the liver. Laceration involves segmental or hilar vessels producing major devasculation. So when there is major devasculation, So this is also rupture subcapsular parenchymal hematoma. So here there is no rupture, but there is rupture and there is rupture hematoma. If you observe for laceration involves segmental or hilar vessel producing major devasculation. Segmental or hilar vessels involving major devasculation. Here segmental vessels is torn and there is major devasculation. Another is laceration, completely shattered spleen. So this one is very important. When there is complete shattered spleen, completely shattered here, so this is grade 5. Now we have to go for the algorithm of the management. Suspected liver splenic injury, contrast CT scan, admission including AST grade, hemodynamic is stable. So we have to first observe whether patient is hemodynamically stable or hemodynamically unstable. If we see that patient is hemodynamically stable, then our planning of management will be some such, and if we see there is patient is unstable, our planning should be changed. Then we have hemodynamically stable, we have to observe AST 1 to 3 or it is above 3. So one very important part is it is below 3 or above 3. So 3 is a demarcation. If it is below 3, obviously there is non-operative management, active monitoring. And if there is a splenic vascular damage, contrast extravasation, yes, then CT angiography, if not already performed, then we have to go for CT angiography. And evidence of extravasation, C2 aneurysm, arteriovenous fistula. Evidence of the extravasation, blush. Discuss radiologically splenic artery embolization. So we have to go for splenic artery embolization. Successful embolization if occurs, yes, then regular physical examination, regular FBC monitoring. What does stands for FBC? I think blood count. Continuous monitoring of the hemodynamic stability 48 to 72 hours. Contrast CT imaging if hemoglobin drops within 48 hours for grade 2 and above. Hemodynamic drop, hemodynamic instability, failed non-operative management, then we have to go for we have to go for the definitive management, that is emergency laparotomy, splenography or splenectomy. Plus we have to go for vaccination within 14 days. Hemophilus influenza, Nausea meningitis এবং Streptococcus pneumoniae vaccination. Now patient is hemodynamic stable, we have to go for non-operative management, so it is very important. Minimal evidence of the blood loss, less than 2 unit packed red cell as transfusion required. Absence of active contrast extravasation on CT scan. Absence of other indication for laparotomy. So when we go for non-operative management, we have to keep this in our mind, that minimal evidence of the blood loss, less than 2 unit packed RBC and as transfusion required. So when we are transfusing blood, only 2 bag is sufficient to keep the patient stable. Absence of active contrast extravasation of the CT scan. So contrast extravasation is very important landmark for the operative procedure, and if there is no other indication for operating management in the laboratory. Length of intensive care unit monitoring should be generally 24 to 48 hours initially, with serial hematocrit evaluation and continuous hemodynamic monitoring. So we have to regularly evaluate the hematocrit. Blood transfusion is limited to 2 units of packed red blood cell. If patient has an ongoing transfusion requirement for more than 2 units, operative management should be performed. Majority of the pediatric splenic trauma is successfully managed operatively. Majority of the pediatric splenic trauma is successfully managed non-operatively. Recovery and recommendation include restricted activity in terms of contrast sport, running, or similar stresses for 3 months following injury. Angiography is performed in patients who are hemodynamically normal and have blush on initial CT scan. So when we will go for operative treatment, this is a very important point. Should be performed in those patients demonstrating peritonitis or hemodynamic instability, those following non-operative therapy and failing non-operative therapy. So he is failing non-operative therapy, and those with gunshot wound in the abdomen. Splenectomy is indicated with significant blood loss, more than 1000 ml or more than significant associated injuries, hilar involvement. So one very important point, the involvement of the hilum of the spleen. So this is very important, that whether the hilum of the spleen is involved or not, there is vascular or arterial or venous involvement present or not. This is important. So hilum is very important, that whether there is hilar injury present or not. Now splenic salvage includes splenography and partial splenectomy. We also have to know that there is this splenic salvage surgery, that is splenectomy or splenography. Splenography can be performed with absorbable mesh. So we can also use mesh in case of splenography. Operative treatment or other strategies includes the use of topical hemostatic agent, include surgical avidin and topical thrombin, as well as the application of the mattress suture to allow tamponade of the hemorrhage. The spleen must be preserved to maintain function. Complication: atelectasis should be treated with aggressive pulmonary toileting, delayed bleeding in the subcapsular hematoma, subphrenic abscess, pancreatic injury resulting pancreatic fistula, thrombocytosis if platelets are more than 10 lakh, OPSI, overwhelming post-splenectomy infection. Now comes to another important topic of today's presentation, is the liver trauma. It is the important point, second most frequently injured solid organ after spleen in the blunt trauma. So the first is spleen and the second is liver. So more common in the penetrating injury, more than 30% than the blunt trauma. Blunt trauma, it is 15 to 20%, but it occur more in the penetrating injury. This is 30%. Motor vehicle collision common occurs in the mechanism of the injury, is known as the for the liver trauma. Posterior portion of the right lobe are most common site. Overall mortality of the liver injury is around 8 to 10%. Overall morbidity rate from 18 to 30%. Blunt injuries are usually more complex and result mortality up to 25%. So again I want to say that the overall mortality of the liver injury is around 8 to 10%. So you have to keep this in mind. This is very important figure, 8 to 10%. Overall morbidity 18 to 30%. Blood injury are usually more complex and result more mortality up to 25%. Most deaths occur in the early postoperative period, means within 48 hours. So we have to know what is early postoperative period. Early postoperative period is within the 48 hours from shock and transfusion related coagulopathy. Because of the transfusion related coagulopathy and shock, this occurs most. Why liver? Liver at first, this is a very large organ, and there is friable parenchyma. Capsule is very thin, the Gleason's capsule is a very thin, and the fixed position is related to spine prone to blunt trauma, because the posterior part is fixed and this is the spine, so which is prone to blunt trauma. Wide bore thin walled blood vessel with high blood flow, excessive blood loss. So here the blood vessels is the thin walled, so very with high flow. So thin wall can be ruptured very easily, and there is blood flow. So there is excessive blood loss. Right lobes larger and closer to ribs, more injury to prone. So also the right lobe is larger and this is more close to ribs. Now come to the association. Associated liver injury is occurs less than 50% cases. Blunt trauma 45% with spleen injury, and rib fracture 33% with liver injury. So isolated injury occurs 50% cases, শুধুমাত্র liver injury হচ্ছে 50% কেসে। Blunt ট্রমাতে more than 45% with splenic injury, and rib fracture 33% cases is associated with liver injury. So if we occur a liver less than 50%, what? Isolated liver injury, then we observe a blunt trauma. This is more than 45%, and if we consider this is associated with rib fracture, there's a rib and there may be crack or fracture, crack or fracture, crack or fracture. This percentage is very high, and this is 33%. History of the blunt trauma, abdominal trauma is a lower chest trauma, direct blow, crushing or fall from height, penetrating injury, right hypochondrium or epigastric area. Blunt injury produce contusion, laceration or avulsion injuries. Penetrating injuries such as step and gunshot wound often associated with the chest and pericardial involvement. Blunt injuries are more common and have higher mortality. Now, if we consider the injury type, there are parenchymal damage, subcapsular hematoma, laceration, ছিঁড়ে গেছে, contusion বাড়ি খেয়েছে, hepatic vascular disruption, ভেসেলগুলো ছিঁড়ে গিয়েছে, and biliary injury. There may be multiple biliary duct and they could be injured. If we consider the mechanism, this is crushing injury, deceleration, sudden increase in intraabdominal pressure. Pathophysiology. The main immediate consequence is hemorrhage. The amount of hemorrhage may be small or large depending on the nature and degree of injury. Many small laceration, particularly in the children, bleeding ceased spontaneously. So it is very, children are the angels from sent by the Almighty. So they are very blessed, and Allah take care of them by them by always take care of them. And so particularly in children, the bleeding ceased spontaneously. In larger injury, bleeding extensively extensively often cause hemorrhagic shock. So if there is extensive bleeding, it could be go in the hemorrhagic shock. Mortality is significant in high grade liver injury. If we can manage very well, the mortality rate is very high. Clinical feature, if we consider history of blunt or penetrating trauma, abdominal pain, features of hypovolemic shock, patient may come with the shock, may be refractory to resuscitation. We could not resuscitate the patient. And signs of peritoneum, guarding rigidity, absence of bowel sound. Other cause of hematoperitoneum: splenic injury, ruptured ectopic pregnancy, ruptured abdominal aortic aneurysm, acute hemorrhagic pancreatitis. Investigation: hematological full blood count, grouping and cross matching, coagulation profile, renal function test, liver function test. First and first, see CT of the whole abdomen with chest, diagnostic peritoneal lavage, diagnostic laparoscopy, hepatic arterial angiography useful in active bleeding in stable patient, transcatheter embolization, stenting of fistulas. Ultrasonography, rapid, non-invasive, portable, focusing on pericardial, hepatic, ischemic or pelvic area. CCT abdomen, accurate in the localizing site of liver injury and any other associated injury. Used to monitoring healing, CT criteria for the staging liver trauma. Now, if we observe DPL, diagnostic peritoneal lavage. In physiology, unstable patient in lung trauma, 1 liter normal saline or Ringer's lactate via the sub-umbilical cut through a lavage catheter. Patient position changed time to time and side to side, fluid aspirated. Criteria: positive lavage, anyone, frank blood more than 10 ml, RBC count more than 10 cmm, WBC count more than 500 cubic millimeter, amylase more than 175 IU, and presence of bile, bacteria, food particle and foreign body. Now, if we consider the AAST, American Association of Surgery and Trauma, if we consider again here subcapsular laceration and subcapsular hematoma, if we consider the hematoma, this is the hematoma and hematoma is same, less than 10%. This is same, less than 1 centimeter. The second issue is also same, this is 10 to 50% one, but there is another one, there is hematoma laceration, and hematoma is in two types. One is subcapsular hematoma and second is intraparenchymal hematoma. This is also less than 10 centimeter. If we observe the grade 3, there is hematoma, subcapsular hematoma. Subcapsular hematoma holo more than 50% area, and laceration is more than 3, and intraparenchymal hematoma is more than 10%, 10 centimeter. Laceration, if we consider grade 4, there is subcapsular laceration, parenchymal disruption involving 25 to 74%, perennial resorption involving 75 to 75%, hepatic lobe or involves 1 to 3 choanite segment. So there is always maybe 3 choanite segment involvement, and vascular injury with active bleeding breaching the liver parenchyma into the peritoneum. So there may be active bleeding or extravasation or vascular injury, active bleeding. Grade 5. Grade 5 is laceration or parenchymal disruption involving more than 75. Previous one is 25 to 75. Then there is vascular injury. It could be vena cava, it could be aorta, major central major hepatic vein, the three hepatic vein, or it could be injured by the vena cava. AAST, One subcapsular hematoma, if we observe here, this is very important, that subcapsular hematoma less than 1 centimeter. So here a superficial laceration less than 1 centimeter deep. Here too 1 to 3 centimeter deep and subcapsular hematoma 1 to 3 centimeter thick. Three parenchymal laceration more than 3 centimeter deep and subcapsular hematoma more than 3 centimeter deep. So here parenchymal laceration more than 3 centimeter deep. IV parenchymal subcapsular hematoma more than 10 centimeter diameter, and there is global right lobe destruction. Global destruction of the devascularization of the liver. Here we can see here there is major devascularization. Here there is devascularization. So this is grade 5. And 6 is hepatic avulsion. Completely avulsion of the hepatic vein. Here there is 6, no 6, so completely shattered. 6. Now, suspected liver injury after blunt trauma. Initial assessment ATLS, fluid resuscitation first. Patient is stable or non-responding to resuscitation with hemodynamic instability with first showing hemoperitoneum. If hemodynamic unstable, exploratory laparotomy. Stable CT scan, further evolution assessment of the liver injury, observation 1, 2, 3. And when there is more than 3 or 4, the patient will need exploratory laparatomy. Management strategy. Initial resuscitation as ATLS protocol. It is important to note the mechanism of injury. Remember the associated injuries: spleen, pancreas, bowel, and clinical pictures may vary from mild right upper quadrant pain through the peritonism to hemorrhagic shock. Consider fresh-frozen plasma cryoprecipitate along with PRBC. Stable patient undergo imaging investigation to assess the injury along with resuscitation. Unstable patient require resuscitation and laparotomy to control the bleeding. Management strategy. Initial management done by ATLS protocol, non-operative and operative management. Criteria for the non-operative treatment: hemodynamically unstable, minimal evidence of the non-blood loss, less than 2 unit packed RBC, and transfusion requirement. Absence of abdominal injury requiring laparotomy, absence of peritoneism, and absence of ongoing CT scan, extravasation of the contrast. And non-operative treatment measures close monitoring ICU with serial hematocrit evaluation and continuous hemodynamic monitoring. Serial abdominal examination usually need to 24 to 48 hours. Blood transfusion is limited to 2 unit PRBC, and patient need more than 2 unit transfusion. Operative treatment should be considered. Majority of the pediatric trauma can be successfully managed non-operatively. Angiography is preferred in the patient who are hemodynamically stable but have contrast splash on CT scan. Strict bed rest is restricted activity in terms of contrast sports, running and similar stress for the last 3 months. Liver injury criteria for the operative treatment. Any patient who is hemodynamically unstable, suspected liver trauma. Grade 4, 5, 6 injury usually requires surgery. So when up to 3, this is conservative, and above 3 and up to 6, it is operative. Multiple transfusion required to maintain hemodynamic stability. So more than 2 PRBC is allowed. The active arterial blush CT for the which iron embolization failed. For ongoing bleeding, CT scan with focal pooling of the contrast. Penetrating trauma. Operative treatment management principles. Goal is to arrest bleeding. Operative room environment: warm heating pad on the OT table. All fluid and blood products should be transfused warm, and prepare dead neck to the mid thigh and upper leg for harvesting saphenous vein graft for vascular injury. Neck of mid thigh. So we have to trap also in the mid thigh. Long midline incision, rooftop incision are allowed to wider access. Consider fresh frozen plasma cryoprecipitated along the PRBC for the transfusion, permissive hypotension and prophylactic antibiotic. 4P push pressure pack plug Pringle is should be the principles of management of choice. Thank you